This is Sharmila Dorbala from Brigham and Women's Hospital in Boston and from the American Society of Nuclear Cardiology. These are extraordinary times, and we thank you all for joining us. The American Society of Nuclear Cardiology is sensitive to the fact that many of you are risking your lives caring for COVID patients. Educational offerings at this time of intense service may be unimaginable with your already burdensome schedule. We respect this and we understand this. We all thank you for your service on the front lines of the COVID pandemic. On the other hand, some of you are being asked to work from home while awaiting your turn to serve. ASNC weighed these two scenarios and decided to support the trainee education at this challenging time by bringing to you complimentary live teaching sessions over the next 2 weeks, which will be recorded and available for viewing for some time later, so that those of you who could not join this meeting can take advantage of these educational offerings at your convenience. Before we get started, here are some housekeeping tips for this conference. You may choose to have your video camera on or off. All attendees are muted by default. Please mute your microphone as that helps minimize the background noise. We will have a question and answer session at the end of the presentation and probably at the end of each case session using the chat feature on the Zoom. So please chat any questions you have. We also will be polling the audience for some questions, and we want you to respond using the chat feature. To post questions, click chat at the bottom of your screen. Once you click chat, type in the window on the right side of the screen. Note that you will see everyone's comments and chats. Please keep comments pertinent to the material covered at this session. To raise your hand at the bottom of the screen, click participants and click on raise your hand. And during the case sessions, we may invite some of the folks who have raised their hands to participate actively in case interpretations. So what is this 2-week virtual nuclear cardiology curriculum? So ASNC has planned virtual live sessions, which includes a small didactic session for half an hour, followed by 90 minutes of case interpretations. These will run starting from today till the 17th of April for 2 weeks on every weekday afternoon, 2 to 4 p.m. In addition, we also have a virtual curriculum that includes pre-recorded lectures posted on the ASNC website. Previously conducted webinars that are recorded are available for your viewing. ASNC guidelines in PDF format are made available, and key papers published in the Journal of Nuclear Cardiology are also available. All of these are posted on the virtual online curriculum that I ask you to check out. This 2-week initial virtual nuclear cardiology elective is brought to you by participation of faculty from several major institutions across the United States: Brigham and Women's Hospital, Methodist DeBakey Heart and Vascular Center, UPenn, St. Luke's Mid-America Heart Institute, University of Virginia, Yale University School of Medicine. This presentation will be recorded. All slides in this presentation are HIPAA compliant. However, if you accidentally see anything, please do not discuss that. Slides are the property of the presenting faculty, and we appreciate your feedback at this link. Finally, become an ASNC member or renew your membership today. This makes all the complimentary material available to you. Just as a reminder to all residents, fellows, and trainees that ASNC membership is complimentary. So let's get started with this virtual nuclear cardiology elective. So I want to set the stage of nuclear cardiology in 2020 before we get on to our presentation of cases. Nuclear cardiology is a mature field with several cutting-edge advances. It plays a key role in guiding patient management. When I trained in the 2000s. I graduated in 2001 from my cardiology fellowship. At that time, the primary techniques that were available for us was perfusion imaging with technetium-based tracers, gated perfusion imaging, quantitation using software. Attenuation correction was just beginning to come into clinical use, and MAGA scanning. Within the 2000 to 2010 decade, we see a major growth in SPECT and PET myocardial perfusion imaging, including hybrid imaging with calcium scoring and CT-based coronary angiography. FDG PET imaging for viability and sarcoidosis have grown enormously. Somewhere around 2010 and later, we see development of novel SPECT scanners, novel software that enhanced image quality and made possible greater quantitation of SPECT. PET and hybrid imaging was growing as well. Currently in 2020, if you're practicing nuclear cardiology, most of you are using SPECT, SPECT CT, novel SPECT scanners, probably performing amyloidosis imaging with technetium 99M PYP, PET CT myocardial perfusion imaging, PET myocardial blood flow, which is now a clinical application and is reimbursable as of 2020. Sarcoidosis imaging, infection imaging, and more cutting-edge research. The future is very bright for nuclear cardiology with immediate applications of SPECT flow, machine learning applications, development of targeted tracers, and theranostics. What are the software advances that improved image quality? As you all know, resolution recovery, noise reduction, and iterative reconstruction have vastly improved image quality of nuclear perfusion imaging. Here's a schematic showing that an object that's close to a parallel hole collimator will have less blur compared to an object that's farther away from the collimator. If we know the characteristics of the collimator, and you know the solid angle subtended by the gamma ray photon from the patient's heart, you can model mathematically and correct for this loss of resolution, which is depth dependent. So this is what is called resolution recovery. In addition, we have advanced noise reduction software. So rather than filtering the noise and smoothing the image, which is what we did in the past, we can now compensate for noise. And we can model the noise much better, saving image contrast from the peaks and troughs. And this advancement in software, all of these three have led to new applications of low radiator dose scanning as well as ultra-fast image applications. The other advantage that you see is the development of solid-state scanners and novel collimators. These collimators collect counts from the heart continuously, and they directly convert the gamma ray into an electronic signal, making it possible to image without the need for photomultiplier tubes. These solid-state scanners are cardiocentric, and tomographic dynamic imaging is a major advance with this scanner technology that makes possible quantitation of myocardial blood flow. Quantitative myocardial blood flow has been evaluated for over 5 years to 10 years now. In fact, it has been studied even with conventional SPECT scanners. But with the novel CZT scanners, the first publication was somewhere around 2013, showing that this is feasible. More recently, comparison of SPECT CT, CZT SPECT camera-based flow was made to O15 labeled water, showing good to excellent correlations. This technique is going to enter the market clinically very shortly. What about machine learning? I think machine learning algorithms are making a big wave in nuclear cardiology. A lot of work led by Dr. Piotr Slomka, Ernie Garcia, and others in this field have shown that using machine learning applications has a better accuracy at detecting obstructive coronary disease compared to stress TPD, stress perfusion deficit, or ischemic perfusion deficit. This kind of technology will enhance the utilization of nuclear cardiology in clinical practice. What about further hardware advances? This is an Explorer total body PET scanner, which provides deep insights into cardiovascular pathophysiology. This can provide very high quality imaging in less than 2 minutes. Whole body images, as you can see in this video, you can actually follow the dynamic transit of the radio tracer injected in the foot here into the entire cardiovascular system. This is possible with ultra low radiation dose imaging late FDG imaging is possible, and whole body dynamic imaging is possible, which opens up previously unimaginable avenues into multi-organ and multi-system molecular imaging and blood flow assessment. The last advance I wanted to talk about was theranostics. Theranostics is the application of a tracer or an imaging agent for diagnosis and for therapy, including therapy monitoring. Look at the schematic here. Cancer cells expressing somatostatin receptors. If we have developed, in fact, this is a clinical application in oncology now, where you have a somatostatin analog, which is linked to Lutathera, and then this combination attaches itself to cancer cells expressing the somatostatin receptors. The use of an agent which can not only detect the surface receptors exposed in the cancer cells, but also then release the therapeutic into the cell to treat the cancer is the next phase in oncology. Theranostic applications are being actively explored and developed in many forms of cardiovascular diseases as well. For each of these reasons, I think nuclear cardiology is a very mature field, yet it is at the breakthrough of molecular imaging, and it's extremely important for all of us to be updated on the latest advances. With that, I'm going to go over to our presentation. So the first nuclear cardiology elective today comes from Brigham and Women's Hospital in Boston. I'm Sharmila Dorbala. With me are two trainees who will be presenting today. Vasvi Singh, who is our Chief CV Imaging Fellow. She's also the chair of the ASNC Fellow in Training FIT Committee. Joining her is Aldo Stignoni, who's a CV Imaging Fellow and also active in ASNC. I'll start off with a 30-minute or less didactic, followed by individual case interpretation. So what are we looking for when we review myocardial perfusion images? So we look at image quality with a focus on looking at signal to noise ratio, image reorientation and angles, image alignment, then review the images. We look at the left ventricular size at stress, at rest, and compare the stress size to the rest size. We look at the right ventricular size and tracer uptake. Then always look at the rotating projection data. Look at myocardial perfusion images, polar plots, and gated images. All of these are described in greater detail in the ASNC SPECT guidelines, which should be available in your curriculum. When we read perfusion scans and see a defect, there are 4 points that we want you to focus on. We would like you to describe the perfusion defect using a vascular territory. Define the size of the defect as small, medium, or large. A defect extending 1 to 2 segments is small, 3 to 4 segments is medium, and more than equal to 5 segments is large. Defect severity is listed as mild, moderate, or severe. Location of the defect, score systematically from apex to base or vice versa, and go by vessel territory. Look at reversibility of the perfusion defects and try to categorize it as mild, moderate, or severe. All of these can be done visually or could be done semi-quantitatively using a scoring mechanism. So how do we segment the myocardium? This is segmented using the ACC AHA guidelines that came out in 2002, led by Dr. Manny Cerquera. So short axis images are, it's a plane of images of the left ventricle parallel to the mitral valve. Vertical long axis images is this blue plane here parallel to the interventricular septum, and the vertical long axis goes from the septum to the lateral wall. The horizontal long axis is parallel to the inferior axis, inferior wall. This is what would be called the 4-chamber view on echo or on MR. The blue plane would be called the 2-chamber view on echo or MR. The short axis is the same. Remember that these 3 cardiac imaging planes are consistent across imaging modalities of CT, MR, nuclear cardiology, and echo. So using those planes, we can segment the myocardium into 17 segments. One segment for the apex. This is on the mid-ventricular vertical long axis slide. Apical short axis is split into 4 segments: anterior, inferior, septal, lateral. The mid and basal myocardium is split into 6 segments each: anterior and inferior. The lateral split into anterolateral, infralateral, septum into anteroseptum and inferoseptum. The defect is scored using this schematic where 0 is normal, 4 is absent tracer uptake. A defect that's mild or equivocal is scored as 1, a definite defect is 2, and a severe defect is scored as 3. We score using the 17 segment model, the stress images, and then the rest images as well. And we could quantify the defect size. If the defect extends into 1 or 2 segments, we call it a small size defect. 3 to 4 segments is a medium sized, and more than equal to 5 is a large size. Having said that, there's some degree of subjectivity to it. For example, if you have the 4 apical segments in the apex, that makes it 5 segments. But this distal LAD perfusion defect, I would still call it a medium size, not large, just because it's 5. It involves 4 small segments in the apex and the apical ventricle. So keep in mind that we try to score the segments, but there's some degree of subjectivity in that your visual read of the scan should correlate with your segmental scores. So we go ahead and score the stress images and the rest images and add the scores in all the 17 segments to come up with summed stress and summed rest score. The difference between the stress and rest score is called the difference score. A score of 0 to 3 is normal, 4 to 8 mildly abnormal, 9 to 13 moderately abnormal, and more than equal to 13 severely abnormal. We can also look at this in terms of percent myocardium abnormal. So think of it as follows. When we're looking at a 17 segment HOT model with a scoring scheme of 0 to 4, the total possible score is 17 times 4, which is 68. So percent myocardium abnormal is calculated as the sum stress score times 100 divided by 68. Percent myocardium scarred or fibrosed is the summed rest scores times 100 by 68. Percent myocardium ischemic, similarly SDS times 100 by 68. In general, we are now reporting perfusion images semi-quantitatively using percent myocardium abnormal. And this is primarily because the ACC/AHA PCI guidelines have made some AUC recommendations based on percent myocardium abnormal. So 0 to 5% would be considered normal for a non-attenuation corrected scan. 5 to 10% is mildly abnormal, 11 to 20% moderately abnormal, and more than 20% severely abnormal. For percent myocardium ischemic, there's much tighter categories. 1 to 5% is mild ischemia, 5 to 10% is moderate ischemia, and more than 10% is severe ischemia. So with that background, I want to go ahead and try scanning one study online. Just bear with me because this is the first time we're using this technology. We want to make sure it works. So I will start off with sharing with you some rotating projection data and then share with you images of one patient. And we will see if we can use the chat function to get your input so that you can actively participate. So rotating projection data, just to bring everyone onto the same page. So these are called by different terminology, but these projection data are looked at primarily to understand normal radiotracer distribution. Remember, technetium is excreted through the hepatobiliary system, so you should see some uptake in the liver. If you don't see uptake in the liver, you see a photopenic area, then you worry there may be cysts in the liver, for example. Patient motion can be identified, particularly with the 2 detector systems where you're doing multi-frame image acquisition. You can see the heart moving up and down if the patient moved. Breast attenuation artifact, you can see this dark shadow overlying the heart. That's your breast attenuation shadow. And this is an image on the conventional sodium iodide detector which can tell you there is a breast shadow. In this case, you'll notice that there's a focus of abnormal increase in radiotracer activity in the left breast. That's abnormal, all right? You're not supposed to see asymmetric breast uptake only on the left side. And this patient turns out to have left breast cancer. We also look at these projections to identify increased radiotracer uptake in the lungs, any increase or decrease in extracardiac tracer uptake. Flashing can sometimes indicate a gating error. This is the projection where you might detect some forms of detector malfunction, particularly with the old scanners and some of the new scanners. So here's the images. We'll start off with myocardial perfusion images just to orient everyone. Stress images are on the first row, rest images on the second row. So alternating stress, rest. Here's your horizontal long axis from inferior to anterior, stress on the top, rest on the bottom. Vertical long axis, stress on the top, rest on the bottom, going from septum to the lateral wall. The next view shows you gated images. We get both the stress and rest images, and unfortunately this is not playing, but gated images should be viewed at. The other cases will show that. So here's where I want to try the chat function. So Aldo, are you on, unmuted?
Yes.
Perfect. All right, so we want all participants to go ahead and chat in your chat function. The left ventricular size in this image, the stress is on the top, rest is on the bottom. Go ahead and type in whether it's normal, dilated, or transiently dilated. So if it's normal, type A, dilated B, transiently dilated C.
Yes, I guess we have a kind of an answer here. Most of people is saying option B, dilated.
Perfect. So we agree with that, right? When you're talking about dilated ventricle, it's a gestalt. We are not showing you volumes at this point. It is a dilated ventricle. When we're talking about transient dilation, remember, we are comparing the endocardial volume on the rest and the endocardial volume on the stress. That is, the TID is developed for static images, not for gated images. Remember that. So here, the inner volume seems to be about the same. So do you agree, Aldo, dilated?
Yes.
Perfect. So now the next question then we ask is, what is the right ventricular size on this image? So focus here, that's your right ventricular size. Is it normal? Is it dilated, or is it transiently dilated?
Okay, I think we have a trend here. Option A, normal.
Normal, yes. So you're not supposed to see, physiologically, the RV should not be visible. The uptake, it should be 1/3 the size of the left ventricle, and there should be no radiotracer uptake to minimal radiotracer uptake. So that is correct. What about RV tracer uptake? I think I gave out the answer. We can probably skip this, should we? Or go ahead and vote. RV tracer uptake is normal, increased, or transiently increased?
Yeah, I think most people select option A, normal, which I agree with.
Perfect. All right. All right. Now this is a question for everyone. So I think each institution and every individual does this differently. So we want you to pick what is the severity of the perfusion defect. Is this perfusion defect mild, moderate, or severe? Go ahead and vote in your chat.
Okay, I think most people is going for severe.
Perfect. Okay, so this is a perfusion defect that's almost absent radiotracer. So it's a straightforward scoring. This would be scored as a defect of 4, right? However, you'll notice that there are parts of the defect which are 3, maybe some parts which are like 2 or 1. So the key is to remember that in a given vascular distribution, in this case, it's the inferior infralateral, we go ahead and select one intensity or one severity score for the perfusion defect, and that is the most severe segment. Why is that? Because we know that defect severity correlates with stenosis severity. So if this is let's say a posterolateral territory or the PDA territory perfusion defect, we would say that the fact that the defect is severe tells us the underlying stenosis in the PDA is likely severe. So that's correct. What is the size of the perfusion defect here? You have your apical, mid, basal slice, vertical, and horizontal long axis images. Go ahead and chat.
Yes, I guess we're getting most of the answers are D, large.
Okay, D is large. Perfect. So I agree with that. So if you went ahead and went by a segmental scheme, you would say it's like 2 segments here, probably 3 segments here. It's 5 segments. And remember, of these 5 segments, 3 are at the base of the heart. So it's half of the ventricle at the base and 1/3 of the ventricle at the mid ventricle. So this definitely is a large perfusion defect. Okay, so this is how we use scoring, a segmental scoring scheme, to arrive at a decision about defect size, severity, and vascular territories. So this is straightforward. Images demonstrate a perfusion defect that is fixed, reversible, or mixed, which is partially reversible. Go ahead and chat.
Yeah, most people go for fixed, which I agree with.
Absolutely. So this is an essentially fixed perfusion defect. At least on these projections, we see no reversibility. So it's a fixed perfusion defect. Now we start testing your knowledge a little bit more because you're all doing super well so far in the first few questions. So at this point, we want you to guess what is the sum stress score on this patient. The stress is the top images. Is this less than 3, 3 to 6, 6 to 9, more than 9?
Okay, I think most people is going for D, over 9.
All right, perfect. So maybe we can stop the session right here. You guys are doing super well here. Absolutely. Some stress score more than 9. You go ahead and at least 3 segments at the base, which are all severe. So you could give it 3, 4, 3, or 3, 3, 3. Right there, you have your 9, and you have 2 segments here, right? So definitely it's more than 9. Some rest score, more than 9. We don't have to vote on this. We'll go on to save time. What's the sum difference score? Go ahead and vote.
Yes, we're getting most people answering A, less than 3.
Perfect. That's correct. The reason I didn't give a 0 is we're not showing you all the slices here. It's possible that there may be some reversibility in between. Less than 3 is correct. So now go ahead and vote on this one. The images show a perfusion defect in the distribution of A is left anterior descending, B is circumflex, C is right coronary artery, and D is multi-vessel disease. Go ahead and chat.
Okay, I think most people is going for C, RCA, but a few answering B or D.
Perfect. Okay. So C, RCA, circumflex multivessel disease. No one picked LAD. That's great. So yes, so the inferior and infralateral walls are overlap territories. This could be subtended by circumflex or by right coronary artery. Therefore, by definition, this could be multivessel disease, right? So the segment in my mind that separates the posterior descending artery from posterolateral is the basal infroseptum. If your basal infroseptum is involved, then we would code it as a posterior descending artery. Now, the PDA does not explain this portion of the defect, which is the infralateral segment. So therefore, this becomes PDA and posterolateral, which could be multivessel disease. If this is a right dominant system, it could be circumflex posterolateral plus PDA. If it's a left dominant system, it just could be single vessel left circumflex, giving off the PDA and posterolateral. So depending on the anatomy, usually I don't like the term RCA. I put it in here just so that everybody's on the same page. Posterior descending artery and posterolateral covers most of the anatomic possibilities. So here's the next question. So this patient, this scan is an inpatient. He was admitted for angina and he had an abnormal troponin. What is the next best step in this patient's management? Would you continue aggressive medical therapy? Yes. In addition, would you perform coronary angiography? Would you perform an FDG PET viability study? Or would you perform an N13 ammonia PET scan? What is the next best step? Go ahead and chat.
Okay, I think we have a little divided audience. I think the majority goes for C, viability study, while the smaller proportion of answers go for A, medical therapy.
Yeah, okay, so both are valid. So everybody needs to get aggressive medical therapy. This patient has definite documented coronary artery disease. So the question is, in the context of a patient with angina and troponin elevation, one of the concerns is that this could be a recent event. And although the defect is very severe, suggesting that viability is unlikely, this patient probably deserves one test, one viability study to show whether or not this is viable. And if on that study we find that this scan is completely non-viable, then you pursue medical management or angiography otherwise. One thing I want you to remember in this case is, with the availability of myocardial blood flow quantitation, it becomes relevant to understand that this is the most severe abnormality, no question. But how confident am I that the anterior, anterolateral, and septal perfusion is completely normal in this patient, purely based on relative perfusion imaging, right? So this is the question, this is the case where absolute flow quantitation and assessment of myocardial blood flow can give us some more information. If this was a PET scan, you would say, look at flow reserve. Would you do an N13 ammonia next? Probably not. Do a viability first. If this whole thing is viable on FDG, then you would go straight to angiography. But the other option could have been N13 ammonia if this was a PET scan to look at myocardial perfusion and regional flow reserve. So go ahead and score this patient. This patient would be counted as severely abnormal scan with no ischemia. So ASNC has standardized reporting guidelines, which is already part of your curriculum package. And what I want you all to think of in terms of standardized reporting is separate the visual interpretation of the scan from how your impression is. So what do I mean by that? What are the scan findings? In this case, the scan findings showed a large and severe perfusion defect involving the mid and basal inferior walls and the basal infraseptal wall that was fixed, right? So that is your finding, where you have 4 elements: defect size, defect severity, defect location, inner vascular distribution, and defect reversibility. The next component of the interpretation is your impression. So the impression is, what are you telling the doctor? So I see these findings in the scan. I think that these findings in this patient represent a medium or large size area of scar in the distribution of the PDA and posterolateral. So put together your findings into both findings and impression as 2 separate facts. So now chat function again. These are just simple cases for us to go through, rapid fire cases. This scan shows an abnormality in the distribution of. Go ahead and chat. All right, Aldo, do we have answers?
Yeah, I think most of the answers goes for A, LAD.
Yeah, so LAD would be right. Anterior wall and septum, LAD territory. I would like to go one step further and say this is proximal LAD. In a normal scan, your very base should be the most intensely or normally perfused territory, and then you may sometimes see a gradient. But when your basal anterior wall is hypoperfused, including the basal septum and probably extending a little into the anterolateral here, this tells us that this is high up in the LAD, a proximal LAD lesion. And here's the angiogram. You can look at the LAD lesion right up there, well before the takeoff of your first septal perforator. Perfect. Go ahead and vote on this one. All right.
Yes, I think we got a few of the people answering mid LAD and some others D diagonal.
Okay, perfect. So the right answer here probably is diagonal. Why do I say that? I say that because the defect involves the anterior and anterolateral walls. It spares the septum. So septal perforators are normally perfused. It spares the distal portion of the ventricle, the apex. So the LAD proper and the septal perforators on this image are perfused normally. Therefore, it's likely to be a diagonal. If I gave you other options, this could also be a ramus intermedius, for example. I didn't give you the option here. And here's the angiogram on that patient. Look at that ostial diagonal lesion. It's a large vessel, but the entire LAD and septal perforators are normally perfused, okay? So when you see sparing of the septum and apex, then you can localize it a little more precisely into a branch of the LAD. Okay, what do you think about this one? Go ahead and vote. You can leave if you want. All right, do we have an answer?
Yes, most people is going for B, PDA.
Yes, PDA, perfect. All right, so this was the point we made earlier. If the inferior wall defect extends into the basal infroseptum, then I would localize this into PDA. If this inferior wall defect extends into the infralateral segment at the base, then I would localize it into a posterolateral, whether it's right or left, but that could be a posterolateral territory. Okay, perfect. And here's an example of a proximal left circumflex. So look at this. Here's your left main, proximal left circumflex, tightly stenosed, diffuse disease, maybe a codominant circumflex here, multiple OMs, and maybe a small PDA. Here's your scan. Look at the basal anterolateral with basal infralateral. So when you have a perfusion defect that involves the inferior wall, extends into the anterolateral at the base, then that is one where I would kind of proximally localize it to a proximal circ, because the anterolateral is explained by a OM, the infralateral is explained by posterolaterals, and maybe a PDA. So this is a proximal left circumflex where your infralateral defect extends at the base into the anterolateral. What about this one? This is probably a two-vessel disease, okay? Here you have an inferior defect that looks ischemic, right? And then you have an apical defect, which is also ischemic. So this is an example of a patient who has an occluded LAD. You can see the faint antegrade collaterals. And here's your catheter in the left. And here's your LCX, which is also occluded. So LAD and circumflex, both vessels are occluded, antegrade collaterals, two-vessel disease. So some people I have heard saying that, oh, this could be a wraparound PDA. I actually don't subscribe to that. The reason being, if it is a very big, large PDA that affects your basal septum, inferior infralateral with the posterolaterals, the septum here cannot be explained by the PDA. All right, the mid to apical anteroseptum is also affected. So this scan is best interpreted as multi-vessel disease. again, coming back to the quantitation story, when you see abnormalities in two vascular territories, how confident am I that the LAD is not impacted in this patient? Not very confident, not very confident. And in fact, you see that here, the patient's LAD is actually occluded with antegrade collaterals. The LAD is occluded, whereas the perfusion looks relatively normal in that territory because that's the most normally perfused territory here. All right, so with that, we kind of conclude our first didactic session. These are the key basic references that should be available to you under your curriculum package. I suggest trainees to look up the stress protocols and tracers document, which is an easy read with a lot of practical guidance on how to perform stress testing, what are the protocols for imaging in various labs. The SPECT guidelines document is much more extensive. That's not an easy read, but it's an excellent reference document. You can go into tables and look at specific tables in that document, and that can provide a very useful guidance for you. Standardized reporting, this is a very important document for ICANN certification and for quality of reporting of your nuclear cardiology studies. And the last document here is cardiac PET guidelines. These are all accessible in the on the website. This document is an excellent resource for those of you performing cardiac PET imaging. It provides detailed protocols in tables, explanations, including a little content about viability and sarcoid imaging. More advanced references for fellows in training and for folks who are starting up new practices. Here's a joint SNMMI ASNC expert consensus document on FDG imaging for cardiac sarcoidosis, myocardial blood flow using PET, and then 2 documents on cardiac amyloidosis, pyrophosphate practice points, and then expert consensus recommendations. I think these are key educational material for trainees as well as for physicians in practice. All right, so let me switch gears here and we'll invite now Vasvi and Aldo to start our next portion of our case interpretation. If you have any questions, please chat your questions while I'm bringing up the next portion, all right? So Aldo, can you check the chat box and see if anyone has questions?
Yeah, no questions so far. I have some questions that I collected from the beginning that we can provide the answer at the end. More logistic questions.
I'm just afraid to unmute folks because then it can become very, very confusing for everyone. So I just wanted to only use the chat for questions at this point. Okay, so who's going to be reading this study? Aldo, do you want to take a crack at this?
Yes.
I'll be driving, so tell me what you want to see and I will go into that screen.
Well, I guess the first thing is to look at the raw data here and the rotatortomos, mainly to see if there's any extracardiac activity within the thorax. I don't see. What I do see is that if you show a little bit on the sonogram, maybe there's a little bit of diaphragmatic attenuation or there's diaphragm coming across there.
Yeah.
All at least this decreases counts and there's some liver uptake.
Yeah,
now
absolutely. So here's your liver to orient everyone. Here's your liver. This is your heart. This is the lung fields. Remember, these are images from one of the cardiocentric detector scanners, CZT scanners. So your heart is in the focal area and everything else is kind of far field. And this rotating projection data is kind of misleading. These are not multiple imaging frames. Rather, these are all images acquired simultaneously from multiple detector heads put together in a rotating format. So as opposed to the standard SPECT images where you use this to detect patient motion, remember that on this scanner, you cannot detect motion looking at this rotating tomo. You could look at this sinogram to detect motion, right? And as the thing projects around, so Aldo made a very important point, which is as you come here, you see that the counts in these projections, which is the detector elements which are far behind the heart on the left side, there's significant reduction in counts on the image. Typically, this indicates attenuation of counts from diaphragmatic attenuation, okay? On this particular scanner, it varies from scanner to scanner, but in this scanner, that's what that indicates. All right, anything else, Aldo? Or should I
No, I
move?
think we're good on that one. I will go to, just I can go to the perfusion images.
What did you want to see?
Then we can
This
go
is okay?
inverted.
Okay. Oh, sorry. Grayscale.
Yes. When we, this is, I guess the first thing that we're looking here is if this is what kind of protocol are we doing here? We can see that based on time, that the rest was done actually after stress. We kind of complicate things a little bit, given that the stress was done with a lower dose. And then actually the rest, which was done afterwards, has 3 times of the dose. So we need to kind of bear that in mind for our interpretation. Sometime going to kind of grayscale, kind of really a little more detail in terms of the count, and can be a little, better appreciated any particular defect. What I see here is that looking at the stress first on the short axis, we see a perfusion defects that extends from through the kind of inferior wall. I would say is a basal infraseptum, basal inferior, basal kind of inferolateral that extends to the mid segment, basal inferior, and mid inferolateral, and perhaps a little bit onto the epicolateral kind of segment. When I compare that to the rest, taking even into account the higher dose, I think there's reversibility, suggesting that is predominantly kind of reversible defects, suggesting kind of ischemia. That would be kind of my take on this particular read.
Yeah, perfect.
If
So,
you size
exactly,
the
yeah, you
defect and
start
the
off with
stress,
LV size, RV
we
size, and
are
pressure uptake.
looking into 1, 2, 3, and 3 more at the base, or at least 5. So medium to large defect of moderate intensity. And particularly here, if we pay our attention to the septum, I think perhaps the septum is involved. So maybe you could say that this is PDA and PLV kind of distribution.
Excellent, excellent. So the only things I would add to Aldo is we usually start off with a comment about the LV size. We'd say LV size looks normal or maybe mildly dilated. The right ventricle is not well seen. We can't comment about the RV tracer uptake. There does not appear to be transient cavity dilation. I fully agree with Aldo's interpretation of the perfusion abnormalities. Very important, our lab protocol has now changed to stress first in all patients unless there's pre-existing evidence of a myocardial infarction. So this is one of those patients who has started with stress first, and this is what the fellows rotating in our lab do all day long during the morning. So they're first shown this image, and as soon as they looked at this picture, they said, oh, the scan is not normal. The only decision at this point when you're looking at stress first is the scan completely normal or not? If the scan is not completely normal, you go ahead and proceed with the resting scan, which is what they did. We went ahead and did the resting scan, and lo and behold, you are seeing some reversibility. So Aldo pointed one fact that this is slightly lower counts compared to this. This is 3 times higher count. In fact, I actually feel that if you do stress first, you have less shine through of activity, and this protocol may be better at detecting ischemia when your rest scan is higher dose compared to the stress scan, because you don't have baseline resting counts on your defect, right? Having said that, the image quality with the low dose study should be decent enough for interpretation. If you use too little of a radio tracer, the image can be noisy. A noisy image at stress may make the resting image look very ischemic when you have a higher dose. In this particular context, if you look at the perfusion, the image quality is excellent. This image is not noisy. So whatever the dose given at this case, we will take a look. This is probably decent quality stress study. This is one of the advantages of the high sensitivity detectors. Even with a low amount of radioactivity injected, you can get decent quality images. So here's your polar plots. All right, Aldo, what do you think?
I want to just take the opportunity well, I mean, let's go here to the polar maps. And certainly we see stress on top. We do see that there's some degree of decreased counting at rest. Some of that might be accounted for some of the diaphragm, but there's definitely reversibility when you compare that segment to the stress. And one thing that is important is that when you do stress first, sometimes you get, and you do D-spec, you get upright and supine. I think it's better when you're doing comparison just to compare apples to apples. As we see here, we're comparing the rest upright to the stress upright. So in there, and then here we're in kind of in the vascular kind of setting, and to try to kind of quantify the percentage of myocardium that has been involved. And we see that is in the RCA territory is 46 of the R territory, and then the total of the myocardium is 32.
Yeah, absolutely. So the defect is extending from inferior to lateral. So I just want to bring all attendees onto the same page, just so that this may be too basic for some of you. But anyway, the first column, this is the patient's polar plots, the stress upright, rest upright, difference. The second column, patient's polar plot compared to a normal limits database, which is listed here. And the pixels that fall outside the two standard deviations are blacked out. Same thing at rest and at reversibility. Now, if I go ahead and show you what is called circumferential count profiles, this is the same data shown in a different fashion. So look at count profiles in this infralateral territory, lateral and inferior. The orange is the patient's data. So the orange is the counts in the patient's polar map. Blue is the database, mean, and the lines below are two standard deviations below mean. So what this is telling us is the patient's counts in the inferior and lateral on the upright are much reduced compared to the database. At rest, they're also reduced, but you can see less different from the normal limits database, and that's your reversibility, okay? So how do we use these polar maps? What I normally do is I interpret the scan, look at the polar plots, and go back to the scan again. Sometimes you pick up things that you may not have visually identified, but the polar plot picks it up. Other times it's the other way around, where you thought there was mild ischemia, but the polar plot does not seem to show ischemia. The reason is fairly simple. The polar plot, since it's comparing to a database, if your counts fall right at the edge, okay? So for example, look at this pixel here. If it falls below the mean, but still within the two standard deviations, that segment is not going to be called abnormal in the polar plot. But when you look at that segment compared to rest, the counts are higher at rest compared to this, suggesting there may be some component of reversibility that the polar plot is not necessarily picking up, but your eye may be picking up. So remember, it goes both ways. Look at the plots, make sure it fits with your eye, and go back again and look at the images. I find the polar plots very helpful for comparing old studies to new studies. In one quick instance, you can look at the polar plot and say, yes, this is new. No, it's not. Very, very helpful. Okay, now quantitation. Here's your gated slices. I guess I have to load the gated images. So upright, gated. Oh, one thing that Aldo already mentioned, which I should have shown, we are performing what is called multi-position imaging. So we scan the patients at upright at rest, but perform supine and upright images for the stress images. So you'll see, I'll go back and show you the scans again. All right, Aldo, what do you think?
Yes. So the first thing is globally, it seems that function seems to be preserved. I guess when we're looking at this, and I saw you put the markings there. We're looking at two things. We're doing like at the motion of the endocardial border as they come in, but also we're looking at thickening, and the thickening is by the change in color scale. So we need to have both to kind of have a normal myocardium. Always be careful that in small defects of myocardial infarction can be missed as a normally moving myocardium just because it's surrounded by areas that are moving and thickening properly. So the resolution is not there for this need for tiny. But here what we see is, which is interesting, kind of also helps with the interpretation, is that, again, you have rest at the bottom. We see that the heart is globally and regionally coming and thickening okay, especially in that kind of inferior lateral. Maybe it's lagging a little bit, but it seems to be coming in and brightening. But when you see in the stress acquisition, we see that there is a significant wall motion that is happening. And when I see this, there's few points that I take from this. Remember that some of these acquisitions are not during peak stress. We're just doing post-stress acquisition sometime, after 15, 30 minutes, depending on the type of stress. So we're just doing post-stress. If we don't always get, especially inspect a kind of a wall motion, but in this particular case, we see that, that inferior lateral kind of segments they do have a wall motion that is not as evident at rest, suggesting some kind of stunning.
Okay, perfect. So let me actually also add to that.
Going back to the to the endocardial.
So the contours. See that the contours are not right. So something very important for all the attendees to recognize is the software is only as good as the user, right? You need to make sure the contours are adjusted before you report the volumes. So how do you do that? I'm sure a lot of times it's the nuclear techs who are processing these images, but it's literally takes 2 or 3 clicks for you to do a quality control and to adjust the contours. So most software is very user-friendly programs. So you adjust your contours. The other thing I see is it's tracking within the myocardium. So that happens when you're, what do you call this? The region of interest has to be outside the myocardium, because remember, this image is a static image. This is not end diastolic or end systolic. So this should be large enough so that the circle can accommodate your end diastolic phase of the image. When you do that, then you have a good chance that the epicardial border tracks the epicardium and not the myocardium. So remember that, then you do, different softwares do it differently, but then you go ahead and adjust your contours, right?
Yeah.
Now look at your EF. So always, before you read your EFs, you have to always check your contours. Sometimes even with the adjustment, you may not see a good image, as in this case. Here, the image resolution is not that great. So you're seeing a super normal EF, right?
Yeah.
Okay, so now let me go back to the images and show you guys the supine, just to point out, because that was an important point. So you have your supine ungated and stress upright ungated. So this was the image that was reviewed by the fellow on the stress first images. So they looked at both upright and supine and then said, there is a perfusion defect. This is not a normal stress first study. Let's get a resting scan. So multi-position imaging is emphasized in the spec document. This could be supine and upright for some of the newer scanners, or it could be supine and prone imaging with some of the older scanners. So remember that, multi-position imaging. All right, so Vasvi put together this case. So we will ask her to share with us what's the story on this patient. All right, Vasvi, you're on.
Okay, so this is a 63-year-old male with known history of a coronary artery disease, and he's had prior multivessel PCI. He does have hypertension, dyslipidemia, diabetes, obesity, CKD, and a family history of premature CAD. And he presented with dyspnea on exertion. Most recent 1 year prior exercise treadmill myocardial perfusion study was actually normal. It was a SPEC study as well. And then his resting ECG.
So actually, Vasvi, let me stop you. So this was probably one of the reasons why we started with a stress first in this patient with known CAD. Yeah.
That is correct. Yes. So most, other than that, his recent ECG was normal sinus rhythm, first degree AV delay, and then therefore he was referred for this repeat SPECT study because of a change in symptom status, which was mainly exertional dyspnea. His treadmill stress test was a standard Bruce protocol. He exercised for about 5 minutes, 14 seconds, equivalent to 7 metabolic equivalents. His heart rate appropriately increased from 75 to 111 beats per minute. And then he did develop dyspnea and typical chest pain with the treadmill symptoms, even though, his age-predicted maximal heart rate was just 71%. His ECG did not show any ischemic changes. He did have some PVC. And then we just have the dose for the stress system maybe here, which was 10.3 millicuries.
Yeah, actually, this point is very important here. So this man has a very abnormal study with ischemia at a low workload, at a heart rate, sorry, they should say 111. At 70% of the age predicted maximum, he has ischemia at a low workload. So that makes it a more abnormal scan than this is your prior study, Vasvi.
Yes, so completely normal, at least compared to the study now. So we can see a marked difference in the perfusion image of the scan today compared to scan 1 year prior. And this was on a similar scanner.
Okay, so what happened to this patient?
So he underwent a coronary angiogram after the abnormal study. And then you can see here that the LAD and then the circumflex system mainly did not have any significant stenosis. There are some minimal luminal irregularities. However, if we go to the next slide, his RCA, which is a right dominant system, has, as you can see, pointed by arrows, and as Sharmila is pointing with the pointer, did have severe stenosis of his distal right coronary artery and severe stenosis of the right PDA artery. So that explains the new findings that we're finding in this inferior inferolateral region. And then therefore he underwent a successful PCI with the 2 drug-eluting stents, and you can see excellent findings of restored TIMI flow in both the distal RCA and right PDA arteries with resolution of symptoms.
Perfect, thank you. So Aldo, any questions in the chat?
Nothing that we can discuss at this point, just more comments.
Yeah, we'll figure out how to make this work a little better in future, but for now, let's.
Yeah, and then one of the suggestions as we move forward, I think a lot of people is saying that if we could do the warm metal and rather than the grayscale, if possible.
The warm metal. Okay, sure. We'll try to show it in both. Just so that everyone understands, I'm kind of trained in reading in grayscale, and I have a hard time scoring the images. And it's also felt that the grayscale may be a little better for image interpretation because it's a linear scale. But yes, I agree with what you're saying. We will also show the cool images. All right, so who's going to read this? Although any of our cardiology fellows on the chat here, I don't see who's on from the Brigham.
I think we have a few of the fellows here. Anyone want to volunteer to read this case? Just raise your hand in the program and I can unmute you.
Yeah, you can raise your hand. So there's a feature to raise your hand and we can see if you're raising your hand.
We can open it to anyone who wants to.
Yeah, any cardiology trainees can raise their hand. If not, we may rely on you to read this again.
Anyone?
I can't see if anybody raised their hand.
No, what is that? Anyone can volunteer to read this.
All right, don't worry, you can read this.
Okay, let's, I think Nico is offering to help. Let me unmute you, Nico.
Yeah. Hi, Aldo.
Hi, Nico. Nice to see you here, man.
I see. Thank you very much for this great presentation and lecture. So you can see the raw data, the rotating data. There is some GI uptake, of course, and I'm trying to see for source of attenuation. There may be some slight diaphragmatic attenuation. I don't see any severe attenuation there. And there's a little motion as well. And I would like to see the, the gating, ECG gating histogram.
Yeah, sorry, we don't have the beat
Oh.
histograms here.
Okay.
So since you raised the subdiaphragmatic activity question, based on these images, right, I position your rest and stress.
Mm-hmm.
I can ask you questions, right? You're okay?
Yeah, sure.
We want to challenge you. If you were to take a guess, was this a vasodilator study or an exercise stress study? How could you tell? Or can you not tell?
I think I see less GI uptake on the stress data, and that makes me think that it's probably an exercise.
Correct. Exactly.
You
So we're trying to
mobilize.
look at the heart to liver ratio, the counts in the heart in relation to the liver. Look at rest. The heart counts are lower compared to the liver. If this was vasodilator stress, you would see splanchnic vasodilation and you would see intense radiotracer uptake in the liver, which you're not seeing here.
Yeah.
Okay, so this, if we were to take a guess, you're right. This we would guess is, you would guess that this is exercise. All right, here are your pictures. So tell me, do you like this color scale or grayscale?
Yeah. This scale is good. First of all, the first thing that strikes my attention is that I think the LV looks a little more dilated with stress.
Mm-hmm.
And I see starting from the apex, like an apical inferior, apical to mid inferior, extending inferoseptally. It looks more like a, I would say, kind of fixed defect. I don't see a lot of reversibility, but I can see that this dilated. The LV looks a little more dilated in my eyes, at least.
Yeah, you made a comment on that. So let's look at the contours here. Okay.
Yeah.
Do you agree with the contours? Probably yes. So that's an important point. Actually, when you go to your processing screen, right, you need to make sure that when your stress upright and rest upright images are sorted, if this is not tracking appropriately, your TRD can be off. So the program reads a TRD of 1.22, right?
Yeah.
I can make it 1.5 or 1.4. See that?
Yeah.
And I can go ahead and cut this short and make it even higher. So remember, so TID has to be visually appreciated. Make sure the contours are right before you report the number. This is one of the common causes where people send me images saying, this patient had TID, we send them to the lab, there was no disease. So remember, so you always check your contours. If the contours are right, then you may have some TID. That's a great pickup, and no perfusion defects. So let's look at your polar plots. Here you go.
Yeah.
Stress, rest, and difference.
So actually, I think the stress images look a little better than the rest, but there's this inferior, extending a little bit inferoseptally, perfusion defect, both rest and stress. So I'm inclined to call like this fixed perfusion defect in the RCA territory.
Okay. So the other point that you pointed was this little apical inferior stuff.
Yeah.
That is a camera specific thing. We see it a lot with this specific camera. We also think that maybe what is called apical thinning, where your apex of the myocardium is truly thinner compared to the rest of the myocardium. So the counts in, let's say, 6 millimeter thick apex are spread into the scanner resolution of, let's say, 10 or 12 millimeters. So it looks like the counts are low because you're taking counts from 6 millimeters and spreading it to 12 millimeters. Whereas the rest of the myocardium is 10 millimeters thick and the counts are spread into 12 millimeters. So sometimes you have this partial volume averaging. It's a simplistic explanation, but that's one thing. So let's look at the gated slices. And let me go ahead and show you the gated images. So what do you think? Again, check your contours.
Yeah.
What do you think about the gated?
So I can see that the LV again is a little dilated. There's this inferior interoceptal wall motion abnormality, which is, I would say, that looks the same between rest and stress.
Yeah.
And I don't know what else to.
Yeah. So no, I think I agree with you. This wall motion I would not necessarily have called. I think the endocardial excursion looks okay here. It's moving okay. But what catches my eye is that cavity looks bigger and the EF is lower at stress compared to rest.
Yes.
Okay, this is a single day study. Again, remember, you know, this is not necessarily accurate when you have a low dose, high dose, but something to keep in mind. So here is the story on this patient. I think this one I'll have to give you the story because else we may not know this. Okay, so this is a 65-year-old who was referred for chest pain and dyspnea, multiple risk factors, taking a lot of medications. He exercised on a standard Bruce protocol. Heart rate went from 54 to 129. Blood pressure went from 110 to 150 systolic. He had dyspnea, but he had 3 millimeter ST depression. So let's see if we can show you the ECG. So here's your ECG, the first page. Okay, there's a summary page. I want to tell everyone that we always look at this, but don't base your interpretation of ECG on this. This is a page I look at always initially because I can see the protocol, exercise duration, how many METs, what was the maximum heart rate, and then I quickly skim through this. Did the systolic blood pressure increase with exercise? Did the heart rate increase with exercise? Okay. What was the exact stress protocol? And then with electronic EKGs, I really like the way you can scroll through this so you can easily pick up ST changes. All right, what do you think about the resting ECG?
So the resting ECG looks pretty much normal. I don't see any Q waves. I don't see any ST changes.
And it's an
so
interpretable ECG. Beautiful.
interpretable.
Maybe a first degree AV block, borderline.
Yeah, borderline PR. Yeah.
Yeah, but here's your stage 1 ECG. Anything?
Not yet.
Okay, so stage 2 ECG.
So then I'm starting seeing some, I would say more like horizontal to upsloping ST depressions, more like horizontal now in 2, lead 2, lead V5, V6, AVF 3, more like horizontal ST depressions, more pronounced now.
Look at that. All right.
Yeah.
3 millimeters horizontal to downsloping,
And
multi-lead associated with AVR.
Elevation. Yeah, I'm more worried about the AVR elevation. It could mean proximal
So
AV
when you
or
see an ST change like this, which is horizontal and more than 3 millimeters, you worry. Okay, this makes you very nervous that this is a real abnormality. And frequently, this is what happens. In recovery, they become more downsloping. Even at a slow heart rate, the patient still has ST depressions.
Yeah.
All right. So very easy to look at ECG, scrolling through, see that 3 millimeter multi-lead ST depressions, AVR ST elevations in the context of a scan, which is not particularly revealing. Look at the images here. All right. So what do you do with this patient? You have a patient where the scan is normal, but the ECG, he did almost 5 minutes, good heart rate and blood pressure, no symptoms, but he had ST changes. So what do you do next?
Yeah, so I think we need to do a catheterization because we have this TID, which is a high risk feature. And if we combine this with the EKG changes and the symptoms and the risk factors, the pretest probability is very high that he has significant disease.
Perfect. Exactly. So I fully agree with you, not just based on TID, but based on the fact that he had objective evidence of ischemia on the ECG, combined with a little bit of TID, symptoms, everything else. And here's his angiogram.
Dr. Orbala, sorry to interrupt. I think some of the people also are pointing to that there was perhaps a little bit of RV, increased RV uptake on this.
Yes, I'll go back to that. Yes, that's a good point. Okay, let's look at that. So ECG here, RCA, we'll go back to that.
Yeah, it's a severe stenosis in the distal RCA prior to bifurcation. And the LAD looks more like, let me see. Left main has osteal disease there,
Yes,
proximal
so
left
I
main.
must tell you, it may not be very apparent, but they had a very hard time engaging the left main after multiple attempts. I'm not showing you all the pictures, but here's the one. This you can see dye washing back into the aorta, and this was a tight osteal left main stenosis, and the patient underwent bypass surgery. So let me go back. The right ventricular uptake is an excellent point. All right. So look at, that's a great point. So look at the LV to the RV ratio. Maybe I should go back to the, hold on. I go back to the 4DM because this is not showing the right ventricle very well. Okay, here I can zoom down. Okay, and oh, sorry, I keep reverting back to my.
So I have to go for a minute. I'm sorry. Thank you. Let me see.
All right, so look at the LV to the RV ratio. There is a suggestion, there's a hint that it may be high. It's not definitive on this, I don't think. We've seen something more prominent than this, but definitely I agree that that should have been here. See, there's tiny bit. So in retrospect, absolutely. Okay, any other questions on this case?
Yeah, so the other question that somebody put into the chat is when to kind of inject if the heart rate, the target heart rate hasn't been achieved, and when meds that the patient achieves is less than 10. So if you can elaborate a little bit more onto what to do with those patients. So low meds, less than 7, and then not at in target heart rate.
All right, excellent question. So basically what do? Is we look at the patient's story. If this is what we call a diagnostic test in a patient who has no previous diagnosis of ischemic heart disease, we always aim for a target heart rate, which is arbitrarily defined as 85% of 220 minus age. Sometimes patients may not reach that at high workload. If it's a diagnostic test, we try to add vasodilator, either on the treadmill or soon after the exercise testing. For pre-op testing, we also try to get a maximal heart rate. If not, we switch to vasodilator. If this is a second opinion test, patient has been referred from Florida or from some other state, drives up or flies up here for a test, we try to do a maximal test. The patients who are referred for evaluation of ischemic heart disease, somebody who has known CAD, prior PCI, maximal medical therapy, now has angina. The question is, how is this patient doing on maximal medical therapy? Those cases, we will perform a symptom-limited exercise treadmill and inject at whatever the heart rate is achieved, as long as the patient has done at least 5 METs in females and 7 METs in males. So in patients with documented CAD, we inject symptom limited at whatever heart rate. In patients with referral for a diagnosis of CAD, no previous documented CAD, pre-op evaluation, second opinion testing, those are the patients where we switch to vasodilator either on the treadmill, we do that sometimes, or immediately post-exercise. That's an excellent question, very important. All right. We can go to the next case, all right? Although, did anyone raise their hands or?
Let me see here. Anyone wants to help here?
I can't see if anybody is raising their hands. I'm glad you're helping me because I would not know. All right, if not, although you can read this, you probably do not know this case, so.
Should I call? Simin, are you with us? You want to just kind of help with this one? Or Philippe?
Do you see them? I don't see them here.
Do you think she doesn't
Okay. I guess I can.
Yeah, just take this case for now and we will have somebody else raise their hand for the next one.
I think we don't have any volunteers so far, so I can take.
Yeah, sure, go ahead. Yeah, I see Simin here logged in. We can ask her for the next case. Okay, go ahead.
Okay. Yeah, sorry about the.
Sonal volunteered, she said.
Sonal. Okay, sorry. Sonal, do you want to do it? Where are you?
Did you unmute her?
Sure. Okay. Great. Thank you. And I guess that we're all here to learn. There should be a kind of a welcoming environment.
Don't be shy. Sorry,
and
don't
okay.
be shy. We are all just trying to make this interactive and learn. This is not. Don't be shy. We're not going to.
It's Sonal's going to do it. Thanks.
All right. Good. Excellent.
All right. So, hi everyone.
Hi, Sonal. Tell us where you're from. Where are you joining us from?
Hartford Hospital.
Excellent. Excellent.
So, just looking at the raw data. So, stress on top, rest at the bottom. I don't see any significant gut. I mean, there is some gut activity, but it's not really interfering with the. Maybe in the rest, not so much in the stress.
Correct.
Other than that, the diaphragm also, I don't see too much of diaphragmatic attenuation or anything.
Mm-hmm.
I see the RV in the
Yeah.
stress, which is a little unusual.
Absolutely. Yeah, here are your pictures.
So,
Do you like to see this color or grayscale?
no, this is easier for me.
Good. All right.
So stress on top, rest at the bottom. So stress images overall look a little better than the rest. But there is a defect in the, so there are two areas really. There is some in the mid anterior septum.
Mm-hmm.
And then there is a defect in the inferior septum, but that correlates more to the RV. So yeah, the main defects that I see is basically anterior, like in the anterior septum, really. There are defects in the inferior areas, but that's mostly in the inferior septal area, which is mostly at the site of RV insertion. And RV appears big. Okay, now we can hear you, Dr. Dorbala.
Yeah. So right here, do you see anything here?
Yeah, that's what I said. It's mostly
Okay.
anterior and anterior, like mostly in the anterior, like a little mid anterior,
Okay.
and a little bit in the mid anterior septum.
Yeah.
The ones in the inferior are the inferior septal are mostly at the RV insertion, so I would discount that. And RV appears dilated.
Right. So the RV appears dilated. Okay. So as I said, I like to look at it in grayscale. So I can see the few decreased counts in this mid to apical anterior segment. It looks at rest and stress. RV looks dilated. If you look closely, you can almost see like a D-shaped septum. You can see the septal flattening here.
Yes.
And then look at your polar maps here. Let me go to your. There you go. So the program agrees with you at rest, but at stress, maybe a little bit, but not more than that.
Mm-hmm.
And gated. So here's your gated slice.
The LV motion looks okay. And like you said, the septum looks flattened.
All right, perfect. So is Vasvi on? I'm going to bring up this is her patient, so she knows. Okay, there you go. All right, Vasvi, you're on. What's the story here?
Yes, so this is a 65-year-old female with no known CAD and was referred for an exercise treadmill, a myocardial perfusion spec study to evaluate for dyspnea and exertion. She does have a history of recurrent atrial fibrillation in the past with multiple cardioversions and ablations. And then she's on medications for that. When she came for her stress testing, her ECG showed rate-controlled atrial flutter, which she seems to be in chronically at this point in time with variable AV block. And then she did a standard Bruce protocol for about 8 minutes. Her heart rate increased from 55 to 155 beats per minute, reaching 100% of age predicted maximal heart rate. The blood pressure response was slightly blunted to 102 to about 108. 60 mmHg. So not much increase. In fact, we would call this a blunted blood pressure response. And then this was a single day protocol in which we used 5 and 16 millicurie of sestamib.
Yeah, so this is something just remind me, we'll come back to at the, and oh no, this is not her ECG. So we will skip the ECG here. So these are the perfusion images, beautifully showing the RV dilatation and increased RV uptake, very nicely captured on the still gated study. And here you go. So why was the CT done on this patient?
Right. So, this CT was done previously to evaluate for pulmonary vein anatomy. As we saw, she has recurrent atrial fibrillation, and then she has undergone, we can do either in our institution in MR, cardiac MR, or we can do a CT, cardiac to look for pulmonary vein anatomy. So that was the reason this study was done. And then, it is very important whenever you're looking at a stress test for a particular patient to look at all correlative imaging that they may have had, so you can make a more patient-centered decision when interpreting the test. So in this CT, we can clearly see that the main pulmonary artery is severely dilated. It's much larger than the ascending aorta, as we see on its left side. And then the other thing you'll see as we scroll down, incidentally, we just found that there was also an anomalous left main takeoff from the RCA, as you see on that side. However, there is no coronary artery calcifications. So
here's your it looks like a single ostium.
Yes,
Well,
very
I'm
close
trying to see if I
adjacent
can
ostium.
stop it somehow.
Right.
Let me play it. Maybe you can see. Focus on this area when it's playing. Somewhere there, you'll see that single ostium right and left coming out with no coronary disease. Yeah, and look at the right ventricle here.
Huge compared to the LV. The RV is dilated, the RA is dilated. So that goes with the increased tracer uptake that we saw with the stress images. So it would suggest stress-induced pulmonary hypertension during the stress test. And this is her TEE, and you can see that was done like pre-cardio version. So these images are available, and you can see the right side is severely dilated, the right ventricle and then the right atrium when compared to the left side.
Yeah, and the PA systolic pressure was high. Estimated PA systolic pressure was high. So yeah, absolutely. Okay, so nice case. Thank you. We will go on to the next patient.
Yes, so a few questions came up through the case.
Mm-hmm.
I guess some of the people are asking how to calculate the myocardial risk, which is, I guess we went through kind of the lecture, but maybe with, more in a practical way.
Yeah.
And then what is our recommendation for patients with atrial fibrillation before, between treadmill tests versus pharmacological stress tests?
Very practical questions. Excellent. So the quantitation piece will go back. So what do you do with AFib patients? So a few things. One is if the patient has atrial fibrillation that's chronic and is rate controlled, we will proceed with exercise test if the doctor has ordered an exercise. If the patient is poor rate control, we may not perform exercise or dobutamine, but we will selectively use regadenoson or vasodilator in those patients. The other scenario with AFib that we've noticed is sometimes patient comes in, someone like this, recurrent cardioversions, and they'll send the patient for a treadmill test a day after the cardioversion. I try to postpone those studies. I think if a patient has been recently cardioverted, you didn't really give the heart enough time to entrain into a sinus rhythm, going ahead and putting an adrenergic stress on that heart by exercise testing may not be the best thing to do. So in those cases, if they need a test before discharge, we will probably sometimes ask them to do a vasodilator study. So both are excellent questions. If the rate is decently controlled, we will proceed with the stress. Usually no problem, okay? All right, so who's going to read this case here? This is a conventional SPECT, not a D-SPECT. This is sodium iodide 2 detector scanner, and you can see each image, okay? Each image is 1 frame. ASNC recommendations suggest that you need to get 62, you see the counts here, 60 to 62 frames are what is recommended. So 64, sorry, 60 to 64, 32 frames for each detector. So each detector gets, so till here, till 32 is one detector, and then 33 is the next detector. So sometimes you will see that there's a little jump in that. All right, so who wants to read this case? Anyone? Any takers?
Any volunteers?
Raise your hand through Zoom conference. All right, if not, Aldo, we'll probably go back to you because we have very little time now, half an hour. We have a few more cases that we want to quickly run through. So why don't you read this?
Yeah, sounds good. So again, this is the regular camera. And again, now here we appreciate motion. Either, one second, yeah. So we can see that there's some degree of breathing motion throughout the frames. And as you said, if this is a 2-head camera, they switch around 32 or so, and then we can see that there's a big gap there, and some of that happens just because the patient gradually move
this is actual motion
acquisition.
This is not at
just
32.
at the camera switch. So for the one head of the camera is going to be the first acquisition, and for the other head will be the last. So if the patient progressively moves through the scan, that's when you see this kind of big change or kind of movement that we see at the middle in the linogram.
So
we see a lot of
middle, right? Do you hear that?
GI, and we see liver uptake. But I guess that is good that is away from the heart.
Yeah. Aldo, can you hear me?
Yes.
Okay. So this motion is not at the midpoint. Just wanted to point out. It's happening at frame 25. So this is real patient motion.
Okay.
Okay. This is not at the 2 detector heads. You can see that on your linogram. You see that little jump right there. Okay. Yep. And then what do you think these lines are? I know at the Brigham, we no longer read these ASPECT cases. So you guys may not be familiar, but what's happening here? These horizontal lines through this.
So I guess as you follow, I mean, I guess if you do the rotator stomach, you go down, you're basically piling up as you rotate. Yeah. So the one on the right of the screen, that's kind of the heart as you rotate. You put it like one below the other one as you rotate. Mm-hmm. And then I guess that on the other side might be probably the liver, I want to say.
Yeah, some of this could be
arrhythmia. You can see horizontal motion or vertical motion in that.
Yeah, it could be arrhythmia. So we'll wait and see. But here are your pictures. So stress and rest, what do you think?
Okay, so going here, one thing that catches my attention, I go first to the stress. Apex to base. There's some motion at the apex, but nothing that is necessarily convincing. However, as I move into at the inferior that extend into the basal inferior and then kind of inferolateral, when I see and compare that to the rest, I guess that some of the so those segments at the base might be kind of similar, but I want to say that if you go invert, and then maybe we can.
Sorry.
Yeah, it's definitely, there's some decreased counts at rest. Maybe it gets a little bit worse in stress. I guess that I would like to see kind of what the polar map also show in that. Yeah, that's, we're seeing is, again, that the basal inferior septum and basal inferior kind of perhaps similar, but then on the stress, I think the effect is penetrating a little more into the mid, which is kind of, I guess, what we're thinking in terms of a little bit of reversibility there.
Okay, what do you want to do next? So
I guess that some of this is fixed. So I guess how we can sort this out, every time we have a kind of a fixed component, you want to say, is this an artifact? This is a true infarct. So again, the wall motion is going to be helpful. And I think we can see a wall motion there in the inferior, which will go with, presence of a defect. So I want to say that it's predominantly fixed, involving the inferior, basal inferior, and then kind of mid inferior. Maybe there's some, mild reversibility. So it's predominantly a fixed defect.
So what can you do to differentiate? What's your differential diagnosis? Fixed inferior wall defect.
So can you open the volume? Can you say it again?
What's your differential diagnosis for a fixed inferior wall defect?
Okay, so the differentials is either one artifact, diaphragmatic attenuation.
Yeah.
The other thing is, an MI. You have a prior.
Yeah. So what did the gated suggest?
So the gated is if you do have a wall motion, that suggests there is a prior infarct.
Yeah. In this case, what do you think?
I think so. I mean, based on the
wall motion is okay here.
Huh?
Wall motion's fine. What else can you do in addition to gating? How else can you get rid of this artifact?
So,
if it is artifact,
there are a few things you can do. If proning is one option. If you think that to get that diaphragm away from an inferior wall.
All right.
Then you can do if you have a CT attenuation correction.
All right. So here's your prone image.
Well, I guess in this case, this was very helpful because by doing the proning, I think you can see that the defect completely goes away.
Absolutely.
No
it was
doubt.
a great example of where prone imaging really helped. Since you talked about the CT, let me show you a case where we used CT attenuation correction, and hopefully all right, this takes a little while to load. We noticed this because it's a SPECT CT study, okay?
Yeah.
So here's your stress tomo. It's a different patient, remember, different patient, okay?
Yep.
And, oh, sorry, this is what I meant to. Okay, so here's your stress recon and rest recon. Different patient, again, you see the inferior wall perfusion defect, excess subdiaphragmatic activity at rest. The question is this an ischemic defect or is this diaphragmatic attenuation? So go ahead and now add your SPECT CT. Okay. What do you see here now?
Yeah, I think the whole or the defect, I think, goes away. I mean, one important thing that have to be careful is just the GI uptake there that can kind of complicate.
Yeah, so when you apply attenuation correction, that's a great pickup. Great pickup. You will see that sometimes subdiaphragmatic activity is scaled up. It's scaled up and it can interfere. So in this case, it doesn't matter because let's look at just this. That looks completely normal. If your AC stress looks normal, it doesn't matter what the resting shows. There you have your normal.
Correct.
So the two ways to get over diaphragmatic attenuation would be multi-position imaging, which is upright and supine imaging, or it can be supine and prone imaging. The other option is to do attenuation corrected SPECT imaging with SPECT CT, or you could do PET CT imaging as well.
Correct.
So let me show you another SPECT CT just because we are on the topic. Just to complete some little information about SPECT CT. Oh, I have to load this again. Okay, so SPECT CT. AC stress, stress without AC, AC rest. Okay. Here are your images.
Yeah, that kind of septum and anterior.
Exactly. So here's a beautiful example of an LAD territory reversible perfusion defect which is seen on the AC as well as on the non-AC images, both. Okay, in a female patient for an LAD territory, part of the defect could be attenuation artifact. But when you look at the AC images, you know this is not artifact. This is a real LAD perfusion defect that looks nearly completely reversible. And look at your polar plots here. You can see that, okay? Beautiful example of how attenuation correction can improve confidence of interpretation, particularly for anterior wall defects in female patients. In this case, when it's a real defect, doesn't matter. Even without attenuation correction, you're seeing it, all right? So key point to remember with SPECT CT is, as opposed to PET, where you look at just attenuation corrected images, with SPECT CT, you need to look at the AC, non-AC, and then make a decision. I don't want to go into review of interpretation of hybrid imaging, which will be covered in a different section, but there's a way you interpret these studies, make sure the quality control is proper, where you look at the fused images of the perfusion and CT to make sure there's no misregistration before we go ahead and interpret this. So if we come back to, okay, now I forget which case that was. Okay, this one, okay. So this was your case that you just read, Aldo. 77-year-old man known on CAD with dyspnea, multiple risk factors. It was a single day tetraphosphamide study, 1028 millicuries, single day low dose, high dose. It was a regadenoson stress, no symptoms, no ECG changes. He is in good health at 83 years of age now, suggesting that what you read as inferior attenuation was probably correct, inferior attenuation, okay? Yep. So let me see. Oh, this was the other case I showed you, the SPECT CT. He's a young patient with hypertension, dyslipidemia, diabetes, evaluation of heart failure. There's a history of prior MI and CABG, so CT was very important in that case. ECG showed LVH with repolarization changes, and it was also tetraphosphamide study, 12.7 and 37.5, okay? Now let me look at this patient, RM03. Okay, so this was the one that we just looked at, the anterior wall defect on the SPECT CT, the third case, 66-year-old woman referred for non-anginal chest pain, dyslipidemia, family history. She only went 4 minutes of a standard bruise, got to peak heart rate, but did develop ST depressions that resolved 5 minutes into recovery. This was a single day rest stress study with SPECT CT imaging, all right? That's excellent. And here's the cap on this patient. Oof. Look at the right coronary. We saw reversibility in the anterior.
Yes.
And there, that's your LAD. It's actually occluded right there, okay? That large vessel that you're seeing is a diagonal. This is the occluded LAD filling by antegrade collaterals. Okay, right here you can see the stump. The diag is large. So this is the SPECT CT with anterior wall ischemia case, okay? Perfect. Now, okay, I have one case that I want to see 15 more minutes. So let me show you 2 more cases without without history. Okay, so yeah. Okay, do we have anybody who can read, or?
Any volunteers?
Okay, this is conventional SPECT again. This is not SPECT CT. Okay, please raise your hand if you want to read this case. I don't know. How do you check if somebody's raising their hand?
Okay, Nico, you're
Yeah,
on.
hi, Alden, Dr. Dorbala. This is Nico from Cleveland again.
Oh, hi. Thank you for volunteering again.
Just
Is
because
Aldo texting you? Maybe he is.
no, actually, no. We messaged through the chat and everything. So, yeah. So we see the raw data. We see some GI and uptake and liver retention. There is a little bit of vertical motion.
Mhm.
I'm not sure if there is some. I'm trying to see if there is lung uptake there.
Or do you like color? Sorry, tell me, Nico. Okay.
Yeah,
Okay.
it's good. So I think there is with stress we can see some uptake in the lung. I haven't really.
How much? Mild, moderate, severe?
I would say moderate to severe.
Exactly.
Yeah.
Definitely. Look at that. So your contrast is at rest. Look at the resting lung uptake, heart to lung uptake ratio. And look at the heart to lung uptake at stress. All right. So since you're doing so well, what are the reasons for increased lung uptake at stress compared to rest?
So in patients who have, for example, multi-vessel disease and they get diffuse ischemia during stress, they have an increase in the LVDP, and that increases the pressure in the pulmonary capillaries, and the tracer stays in the lung. So that's a marker of like decrease in LV function during stress.
Okay. Any other reasons? Any type of valve disease or lung pathology?
Sure. I mean, you can have mitral stenosis. You can have even severe MR.
Yeah, agreed. Mitral stenosis patients, you may expect something like that. Lung disease patients can also show selective uptake only following stress. So here are your stress rest images. What do you think about the LV size, RV size, tracer uptake, and then the defects?
Yeah, so LV size is a little dilated, more dilated with stress. I see some RV uptake with stress as well. And so it goes LV size. And in terms of defects, I see the inferior inferolateral wall, inferior mainly starting from the apex, extending to the mid and less basal. And it looks predominantly reversible with rest. And I can see also, it extends really apically. I can see the horizontal long axis and vertical long axis views. There's a reversible defect involving the apex too.
Why do the stress images look so poor? Do you think the dose infiltrated in this patient and you're just seeing resting counts?
That's a good question. I'm not sure, but I see RV uptake though, so I believe. I guess I believe.
Remember, this is three times the dose, right?
3 times, yeah.
We gave 10 millicuries here, and this is 30 millicuries, and the image signal to noise ratio is much worse in the stress compared to rest.
Yeah.
No, you can ask a question.
So dose infiltration is a definite possibility, but in this case, you're seeing TID, you're seeing RV uptake, you're seeing multi-vessel ischemia, LAD territory as well as the other territory. So there's your polar maps.
Yeah, we can definitely see the apical apical inferior reversible defect, which is severe, and in terms of wall motion.
So let me adjust this just to be sure that we're doing this right. So gated stress, gated rest, and move this closer. All right, you agree with these contours?
Yeah.
Okay, so
there's a drop in the ejection fraction with stress, and I would say the inferior wall to me then doesn't
right,
brighten.
I need to stop you right there.
Yeah.
The gated stress is pretty much uninterpretable for wall motion. Okay, this
Yeah.
so count poor from extensive diffuse ischemia. I think I agree with you. The EF appears to decrease. The cavity appears to dilate. So both stunning, post-ischemic stunning is a possibility, and diffuse decrease in counts is a possibility. But when the counts are so poor, in this case, this is not, we don't believe it's because of radiotracer misinjection, but in fact, it's because of diffuse ischemia, all right? So in this case, we believe that this actually is a patient who went on to have a cath which showed 95% ostial left main stenosis. It was a very tight left main stenosis. And one other point I need to make here, which Aldo made upfront, look at the study date, 23, rest is on 23rd of July, stress was done on 22nd. So it was a 2-day study with equal radiotracer dose injection. So this is definitely not residual activity for rest injection. On a 2-day study, your EF should be similar at rest to stress. So if it is not for an equal radiotracer, this indicates post-ischemic stunning. And what Aldo mentioned briefly earlier, the blood flow to the heart muscle is this image, the static image represents blood flow to the heart muscle at the time of radiotracer injection, which in this case was when the patient was on the treadmill exercising, you gave him the injection. So the uptake of the myocytes happened while the patient was on the treadmill within the first 60 to 90 seconds, which is why you continue exercise after the trace is injected. But the wall motion, this scan is obtained 15, 20 to 45 minutes after, sorry, it's just, yeah. These images are obtained about half an hour to 45 minutes post-exercise. So as opposed to stress echo, where you're scanning the patient and if there's severe ischemia, you tend to see cavity dilation and real ischemia. With nuclear images, what you see as TID is global subendocardial hypoperfusion. And what you see as a wall motion and drop in EF at half an hour to 45 minutes later is post-ischemic stunning. What is that? It is the myocardium that's affected by exercise-induced ischemia, and it is so stunned from the ischemic insult that the function has not recovered even 45 minutes later. All right, so this is a high-risk marker. This patient, based on all of these findings, would be considered to have left main stenosis. There's a beautiful paper published by Dr. Kim Williams' group from University of Chicago, which showed that if you see this marker of transient RV uptake, this is a high specificity indicator of left main stenosis, 93% specific, where the left main stenosis is more severe than the ostial RCA stenosis. Why is that? Think of it, why is your RV tracer uptake increasing? It's increasing because the demand on the right ventricle for oxygen is increasing. The only way that can be met is by increasing blood flow to the RV through the right coronary artery. So in this case, global subendocardial hypoperfusion, high LV and diastolic pressure transmitting back to the RV, increasing RV wall stress, therefore increasing RV oxygen demand, delivery of blood flow through the RCA. Now think of a scenario if this patient had an ostial RCA narrowing, which was 99%, and the left main was 95%, you may not see this transient RV uptake. So if you don't see this finding, don't automatically assume that this is not a high-risk feature. If you don't see RV tracer uptake on exercise testing, it may be because the patient has multi-vessel disease, including ostial RCA stenosis. So that is something to keep in mind. You have an entire nice talk coming up shortly about high-risk features. So that is something that that talk will go over these findings, okay? So we have 5 minutes and I just want to show one case. And here's the case. All right, Nico, since you're on, maybe you can take this case as well.
Oh, right? Sure, yeah.
Patient is a 68-year-old with recurrent angina with left arm discomfort, prior cabbage, has a lima, SVG2OM1 PDA, multiple risk factors. Here is the scan. Coming in with chest pain.
Yeah, I see some apical inferior inferolateral defect with stress. Looks reversible at rest. And also, I'm a little worried about the anterior wall as well, more towards the apex. More like, yeah, the milder defect there. And the apex, of course, yeah, the apex is worse with stress. Yeah.
So here's that.
Yeah.
All right. So what do you think? Ischemia and mitrodistal LAD at a modest workload. So what's going on in this patient with prior cabbage?
Well, he has a limb of the LAD. He may have some native LAD disease distal to the anastomosis. Lima disease, of course, is in the differential, but it's kind of rare in general. So I was thinking maybe native LAD. Yeah, let's see.
Okay, here's your Lima.
Yeah.
Here's your native LAD, which doesn't show any obvious tight narrowing.
Okay.
So what do you think is going on here? The patient says whenever he is working, he feels some pain in his arm.
So he has maybe has some subclavian, significant subclavian stenosis, and he.
There you go. Outstanding, outstanding. So here's the subclavian stenosis. All right. So the Lima is okay, but the patient has a very tight subclavian stenosis with steel phenomenon, and that was fixed. Excellent, excellent. Thank you very much.
Thank you, Dr. Bala. Thank you.
All right. So I think we are 2 minutes to 4 o'clock. I just want to thank all of you for attending this session. Please send us comments. We do have a little link on the ASNC website where you can go in and enter the evaluation for the session. Please join us whenever you can over the next 2 weeks. And most importantly, stay safe. And thank you for all your service. Thank you.
Thanks everybody for all the comments.
And Vasvi and Aldo, both of you, thank you very much. Nico and others who read the scans as well. Thank you.
Thank you, everybody.